ZolifeFest proudly supports cardiovascular education initiatives like CardioNerds. The landmark SCD Protect trial is now published in the European Heart Journal. Using data from 19,500 consecutive LifeVest patients, this independent trial evaluated sudden cardiac arrest in reduced EF patients during the early phase of modern GDMT optimization. The key finding is a substantial early phase risk of SCA due to VT or VF in both ischemic and non-ischemic patients. See the latest results at scdprotection.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
All right, cardio nerds, this is Colin back with another exciting episode of our AFib series. Today we are diving deep into some challenging scenarios in atrial fibrillation management. We are truly honored to be joined by an outstanding expert in this field, Dr. Bradley Knight from Northwestern Medicine. I am here with my series co-chair, Kelly Arps, and Dr. Yao from William Beaumont University Hospital. Take it away, Yong.
Hi everyone, I'm Yong. It's my pleasure to introduce Dr. Bradley Knight. Dr. Knight earned his medical degree from Ohio State University after completing his training in intern medicine, cardiology, and cardiac electrophysiology at the University of Michigan. He joined the Michigan faculty in 1997. He later served as the director of cardiac electrophysiology at the University of Chicago from 2002 to 2009. Currently, he is the director of cardiac electrophysiology at the Northwestern Medicine and the Shasta and Deborah Cooley Distinguished Professor of Cardiology at the Northwestern U. Additionally, Dr. Knight served as the editor-in-chief of several prestigious medical journals, including the journals of Cardiovascular Electrophysiology and EP Lab Digest. Dr. Knight, we are incredibly excited to have you with us today.
Thank you. I'm excited to be with you. I'm excited to be a cardio nerd for the evening and appreciate the introduction.
Well, thank you again for being here. So before we get into our busy clinic schedule for today, we're going to play a quick game of true or false to recap some of the learning we've had in this series so far. So true or false? All patients with atrial fibrillation should always be treated with rate control first if asymptomatic, and rhythm control should only be considered when rate control is unsuccessful.
Should all patients be treated with rate control before rhythm control? I would say that's oversimplifying it, and the answer would be probably no. Historically, we started with rate control and would only proceed with rhythm control if we don't think patients improve with rate control alone. We tend to use these in combination, and our threshold to recommend rhythm control is much lower now. I think a perfect example is a person who has newly diagnosed persistent atrial fibrillation, who is very symptomatic. They should probably be cardioverted shortly after they're diagnosed, rather than treated for weeks of tapered or escalated doses of beta blockers and drugs for rate control. So no, I don't think that patients need to be on a full rate control strategy before being considered for rhythm control.
And that absolutely fits with what other experts have discussed on some of our earlier episodes that, I think a lot of us think about it as you almost have to find a reason not to want to rhythm control a patient. And have highlighted that a lot of patients who seem asymptomatic may actually feel better once in sinus rhythm.
Yeah, that's another important concept. But just in general, I can't tell you how many patients I've seen who are very symptomatic and they seek medical attention and they're just repeatedly treated with rate control. In fact, I just saw a patient who was out of state in California and went to the emergency room 3 times within a month complaining about atrial fibrillation that really had started a couple weeks earlier. And she was just treated with rate control and sent home. And I think it's important to be very comfortable electrically cardioverting patients, whether in the ER or in a hospital or in your practice. So we shouldn't let patients suffer in atrial fibrillation when often the only thing they really need is an electrical cardioversion.
Absolutely. And then our second true or false question for you, Dr. Knight. True or false, catheter ablation should only be used for treatment of atrial fibrillation if the patient has failed at least one antiarrhythmic medication.
Yeah, that was probably true a few years ago. More recently, we've lowered our threshold to recommend an ablation without trying medical therapy. And it's particularly a good option for patients who are young, who don't want to take antiarrhythmic drugs for a long time. But we have data now on kind of 2 categories that allows us to recommend catheter ablation as first-line therapy. One is that we know if we wait too long, patients can develop persistent atrial fibrillation. And at that stage, it can be more difficult to treat. And number two, our ablation techniques and catheters and tools have improved so much in the last few years that the efficiency and safety of the procedure is much higher.
Thank you, Dr. Knight. So we all know that aging increases the risk of atrial fibrillation, but how about AV in young patients in their 20s? Is that really a thing? Let's take a closer look at the case from the CardioNerds clinic. So we have Miss Flutterman, a 21-year-old college student who came in for a routine physical checkup. She doesn't have any significant past medical history, but she has been experiencing intense palpitations. She thought they were from her stress and anxiety with finals coming out, but they're not actually bothering her almost daily, so she presented to us. We get an EKG, which reviews sinus rhythm with pre-excitation. We hook her up on a 14-day event monitor, which shows episodes of paroxysmal atrial fibrillation. So, Dr. Knight, can you tell us how common AFib is in pre-excitation syndromes like Wolff-Parkinson-White, and why it may be more dangerous than a regular AFib without an accessory pathway?
Yeah, that's a great question. So the scenario you propose is a very young person with ventricular pre-excitation who has palpitations and was given a monitor. Atrial fibrillation is actually quite uncommon. What you would expect to find in a patient who has ventricular pre-excitation and rapid palpitations would be SVT, and in the form of AV reentry, orthodromic AV reentry, where they have a macro reentrant circuit over the AV node and backed up the accessory pathway. This can happen in people with concealed accessory pathways, but in the patient you presented with symptomatic ventricular pre-excitation, which is the Wolff-Parkinson-White syndrome, they usually have AV reentry. They can also have antidromic AV reentry, where it goes over the accessory pathway and up the AV node and can produce a wide complex tachycardia that mimics ventricular tachycardia. To just have atrial fibrillation on a monitor would be a little unusual, but it's important because when you have atrial fibrillation, you no longer have just the AV node as a governor between the atrium and ventricle to control the rate. You have an accessory pathway that's usually capable of not just fast conduction, but frequent conduction. It has a short refractory period and is capable of conducting from the atrium to the ventricle very quickly and repeatedly, and leads to very rapid ventricular rates, which can result in ventricular fibrillation and a cardiac arrest. But the scenario you presented is a little unusual because most people with ventricular pre-excitation and symptoms who present with atrial fibrillation first have AV reentry. So they have AV reentry, and that rapid rate, and probably due to eccentric activation of the atrium, precipitates atrial fibrillation. So the reason why most people with WPW have atrial fibrillation is because they have PSVT that degenerates into atrial fibrillation. Both are very important to be treated. If anybody has ventricular pre-excitation and has symptoms, syncope, rapid palpitations, documented arrhythmias, that's really almost an urgent, important topic that the patient be treated with catheter ablation.
Thank you. So we talk about catheter ablation for these patients. Is it something that we will recommend as a definitive treatment for them? And how successful for catheter ablation in this patient?
Yeah, so in general, this is a class 1 indication for catheter ablation. There would be a rare scenario, maybe a patient had a contraindication to a procedure. Maybe they live in a developing part of the world where that's not an option. In that case, an antiarrhythmic drug like flecainide could be used to block the accessory pathway. How successful it is very high. The likelihood of successful ablation of an accessory pathway is over 98%. We have multiple techniques now and ablation tools that really allow us to map the accessory pathway insertion between the atrium and ventricle and successfully target it with radiofrequency ablation. But with respect to this patient, if they really have atrial fibrillation, that doesn't always go away. Now, the risk of a cardiac arrest would go away if you get rid of the accessory pathway and the pre-excitation, but there are a subset of patients who seem to just be prone to have atrial fibrillation. There are young patients with atrial fibrillation, even though it's mainly a disease of aging. But there are some patients who will have atrial fibrillation, Wolff-Parkinson-White syndrome, have a successful ablation, and rarely continue to have episodes of atrial fibrillation and need treatment for that.
So Ms. Flutterman's very surprised by her diagnosis, and she has finals coming up. She really wants to take some time before she's ready to go forward with an ablation. So, you mentioned briefly some medication options to treat patients with accessory pathways. Can you go into a little bit more detail about the do's and don'ts when it comes to pharmacotherapy for patients with Wolff-Parkinson-White syndrome and atrial fibrillation?
Yeah, most of these patients are young, so we don't have to worry about some of the contraindications to sodium channel blockers. But as you know, there are 6 antiarrhythmic drugs that are commercially available and widely used. Flecainide and propafenone are sodium channel blockers. Sotalol and dofetilide or Ticasin are potassium channel blockers. Amiodarone is a multi-channel blocker, and the derivative dronedarone is less toxic. So you really have 6 drugs. The sodium channel blockers are probably the best choice for patients with an accessory pathway. They block sodium channels and will often eliminate the pre-excitation. So if there needed to be a delay in therapy with an ablation, I would recommend flecainide, usually 50 to 100 milligrams twice a day. There would be the option of propafenone as well, but it's just not used as much. It has some beta blocking effects as well. I would not use amiodarone because it will build up in the system and then it may take a while to wear off if you're planning to do an ablation procedure. So I think this patient probably would want to have a nice excuse to not take their finals. And so I would talk them into having the ablation before taking a drug.
On that vein, people talk about the concerns with AV nodal blocking agents of various different types, really anything that will slow AV nodal conduction in these patients. Do you have concerns about using AV nodal blocking or slowing agents in patients who have an accessory pathway and atrial fibrillation?
Well, for sure, if they have atrial fibrillation, you don't want to block the AV node. When they're in atrial fibrillation, most of the QRS complexes are wide. That means they're conducting over the accessory pathway. Now, there are some people with WPW and an accessory pathway with a very long refractory period, and they'll have atrial fibrillation, and you don't see any pre-excitation. But the vast majority of those patients will have very frequent conduction over the pathway and have a wide QRS complex. If you block the AV node, number one, you're probably not going to have much of an impact on their ventricular rate. And number two, because you're not going over the node and going back up the accessory pathway retrograde, you're not concealing into the accessory pathway, you will likely result in more frequent conduction over the accessory pathway and the potential for ventricular fibrillation. So if you're taking a board exam, the answer is do not give an AV nodal blocking drug in that scenario.
This is interesting. This is something I've always wondered about with this possibility that you could speed up conduction over the accessory pathway if you block the AV node. Because it always seemed to me that at least all of these beats have some degree of pre-excitation. So you're making it through the pathway and you're depolarizing the pathway and getting to the ventricle in every single beat, which I thought at least would limit the ability to conceal antegrade into the accessory pathway and limit the effects of AV nodal conduction or ventricular depolarization through the AV node on the refractory period of the accessory pathway. So I was always a little interested how, it seemed like the maximum or the minimum refractory period or the maximum heart rate that an accessory pathway could conduct at should be similar, regardless of whether you conduct on the AV node or not. But it sounds like you could actually speed up conduction through the accessory pathway or make it more frequent by blocking the AV node.
Well, you raise a good point. If there's conduction over the AV node and not over the accessory pathway at all, and that does happen, you'll see some narrow beats, then you could have concealed retrograde conduction up the pathway and slow the ventricular conduction over the pathway. But there are probably other reasons too why it's dangerous. One, verapamil and beta blockers lower their blood pressure, and they're often kind of hypotensive, and you can lead to coronary ischemia and hypoperfusion. The other potential is if you make these QRS complexes all wide and there's no longer fusion where the complexes are partly over the node and over the pathway. If you create a very wide complex tachycardia, you introduce some dyssynchrony, much like you do with ventricular pacing or left bundle branch block. So you can imagine that would also have a negative effect on ventricular function.
That makes a lot of sense. Well, after that great discussion, we are now getting another consult from the emergency room. Miss Beatrice, she goes by B. Tacky, is a 30-year-old G1P0 at 10 weeks gestation who recently presented to the emergency department with sudden onset palpitations and shortness of breath. Her EKG confirms atrial fibrillation with rapid ventricular response at 150 beats a minute. She has no prior cardiac history. She already has labs, including a TSH, that are unremarkable. And on bedside point-of-care ultrasound, her left ventricular ejection fraction appears to be normal. Dr. Knight, it seems like pregnancy makes all internists, including cardiologists, a little nervous. What's your approach to acute management of atrial fibrillation in patients who are pregnant? And to your knowledge, what agents would be safe to use for antiarrhythmic drug therapy in pregnancy?
That's a very good question. In general, this is a pretty uncommon problem. I'm actually seeing a patient tomorrow who's pregnant and who was having palpitations and on a monitor has a very high burden of paroxysmal atrial fibrillation. You're presenting, though, a patient who presents highly symptomatic with rapid rates with persistent atrial fibrillation to the emergency room. And I'll start by saying that the principles in general is if you're taking care of a pregnant woman with a cardiovascular disease or a cardiovascular acute problem, the goal is to protect the mother. The fetus is not going to do well if you err on the side of protecting the fetus but not taking care of the mother. So you really have to take care of this patient, make sure she's hemodynamically stable. I wouldn't hesitate to provide some rate control with beta blockers or calcium channel blockers. I would probably, like most patients, allow her to convert on her own. Probably 50% of people who present to the emergency room will convert spontaneously when they present with atrial fibrillation within the first 24 hours. So although we give these patients IV diltiazem and beta blockers and they convert, and it's commonly said, well, they converted with, the diltiazem, they did not. They converted spontaneously, but you allowed them some time to tolerate the arrhythmia. So I would start by treating this patient with rate control. If they continue to be symptomatic, you can try to chemically convert them. There are drugs that are commonly used in pregnancy for atrial fibrillation. We try to avoid all of these drugs in the first trimester, of course, but, again, you have to use your judgment. I'll use an example of the patients that we see probably more commonly who have fetal atrial arrhythmias. So when a pregnant woman has a fetal tachycardia, fetal SVT, they look at whether there's high drops or not, meaning does the fetus have any signs of congestive heart failure? And we'll pick usually flecainide or sotalol. So we have a lot of experience using both flecainide in pregnant women with fetuses who have tachycardia and no high drops, and sotalol in the women whose fetuses do have high drops while monitored in the hospital. So we're pretty comfortable using these drugs. I think that would be an option, is to start the patient on an antiarrhythmic drug. But I think it's also important to know that you can safely electrically cardiovert a patient who's pregnant. You can involve maternal fetal medicine so that they can monitor the heart rate of the baby. But if you deliver a shock to the mother, the risk to the fetus is incredibly low. And so, again, I wouldn't hesitate and undertreat this patient because she's pregnant. And so there's a evolving opinion, I think, on the safety of all cardiovascular medicines, or all medicines for that matter, in pregnant women. And I think there's more of an appreciation that many of these drugs are safe. So there is some concern in late pregnancy and at the time of birth, if a mother is on a beta blocker, that there may be fetal bradycardia at the time of delivery. But in general, these drugs are pretty commonly used. And I would probably quickly refer to one of the cardiologists in our program who specializes in taking care of pregnant patients. I would talk to the OBGYN who's taking care of this patient. So hopefully she'll be rate controlled and spontaneously convert. The next question is anticoagulation. She probably has a CHA2DS2-VASc score of 0 except for being female and wouldn't meet criteria for anticoagulation, but often we err on the side of putting them on heparin, which is tolerated during pregnancy because they're probably in a hypercoagulable state.
And then just one brief follow-up question, because that was phenomenal. This was basically everything that we were wondering about this case all in one. If you were to start this patient, say, on just a beta blocker, they didn't need antiarrhythmic medications, because of the possible risk of fetal bradycardia or hypoglycemia with delivery, would you, if they were otherwise doing well and not having a lot of episodes, wean them off of the beta blocker a week or two before delivery to try to avoid that? Or do you just continue it through delivery?
Often I leave these patients on it through delivery. It's likely that during the labor and delivery, there's going to be more of a stress and you're going to face the issue. So I would have a conversation with their OBGYN and some other specialists in cardiac disease during pregnancy, but I have patients who have stayed on their beta blocker up until the time of delivery. The patients that cardiologists take care of are high risk for other reasons when they're pregnant. They have a cardiomyopathy or something else. And so often the delivery is planned section. And so beta blockers potentially could be held for 24 hours if there's really a concern.
Perfect. That's very helpful. Well, unfortunately, our clinic continues to move on without us after we saw this consult in the ED. So let's get back to clinic and see our next patient. Our next patient is Mr. Lewis Arthur. He's a 48-year-old male, and he was born with tetralogy of Fallot. He underwent complete surgical repair in infancy around 6 months old, including ventricular septal defect closure, pulmonary outflow tract resection, and patch augmentation of the right ventricular outflow tract. At 25 years old, he developed significant pulmonary regurgitation leading to RV dysfunction and underwent a pulmonary valve replacement with a bioprosthetic valve. Since his surgery, he has been stable with NYHA class 2 symptoms and moderate RV dysfunction. He now presents with intermittent palpitations, fatigue, and shortness of breath, especially during physical exertion. An outpatient monitor is ordered that shows paroxysmal episodes of atrial fibrillation lasting up to 6 hours. So, Dr. Knight, this is clearly a complicated patient, an adult congenital patient, though there will be a lot of variability in this population in terms of how you approach management, and obviously different adult congenital heart disease disorders will be approached differently. But in this patient who has tetralogy of flow and AFib, what factors make you more or less likely to consider rhythm control up front, and how would you approach this complicated patient?
Well, you presented a difficult challenge. You have a patient with corrected tetralogy of flow who now has documented atrial fibrillation. These patients are at risk of both ventricular arrhythmias and atrial arrhythmias for two reasons. One is the scar on the heart from their surgery. And you have to think very carefully about how the surgeon did their surgery. Even someone with a VSD repair has an atriotomy scar. They usually enter the right atrium, go through the tricuspid valve to repair the VSD. So patients, even if they didn't have an atrial surgery, they often have a lateral right atrial scar from entry to the heart. And the patients who have had corrected tetralogy of flow, of course, also have ventricular scar and are at risk for ventricular arrhythmias. So you presented someone with atrial fibrillation. The other reason they could have atrial arrhythmias besides scar is just atrial dilatation from, in this case, probably a long history of pulmonic insufficiency before they had that fixed, stress on the right ventricle. You mentioned some right ventricular dysfunction, and probably increased pressure in the right atrium. So when we think about atrial fibrillation, there's this reaction now to immediately think of the pulmonary veins. And we've learned a lot about paroxysmal atrial fibrillation in patients without structural heart disease. And the pulmonary vein tissue is a very common source of triggers and reentry. But that's not true for all patients. And in a patient like this, I'd be a little bit concerned that there are multiple areas in the atrium, including the right atrium, that could be a source of their arrhythmia. So I might not immediately think of a, quote, AFib ablation, which usually means isolating the pulmonary veins. That may not solve the problem. And it's hard during the procedure to really prove where their AFib comes from. It is true that when someone's in atrial fibrillation, there are newer techniques that allow you to potentially identify targets for ablation rather than just using a purely anatomical approach targeting the pulmonary veins or maybe the additional ablation of the posterior left atrium. There are selective ablation techniques that are electrogram-based, and there are several strategies and companies looking into even AI-based ways of trying to look at the electrograms and say, well, this is probably what's driving the AFib, and we can target our ablation here. And that's the kind of technique that might be applicable to a patient like this. I would probably, in a patient like this, though, try an antiarrhythmic drug. You can't try a sodium channel blocker in someone with this structural heart disease, but you could put them on sotalol or probably in this case, dofetilide. So I would give that consideration. Now remember, these patients usually have a wide right bundle branch block, and they might have a QT interval that's too long to tolerate that. They might have some renal insufficiency. So you have to have pretty normal renal function and clearly normal repolarization before I would try that.
And I apologize if you touched on this already, but what about amiodarone in patients like this? Is that a drug that you would consider also?
Amiodarone in someone with atrial fibrillation and corrected tetralogy of flow would be a safe and effective option short term, but I worry about the long term. He said he had his surgery when he was 25, and I don't recall how old he is now, probably in his 30s or 40s. So you'd hesitate to give someone like that long-term amiodarone.
Wow, that's a lot to consider. I do agree that multidisciplinary collaboration will be another key to managing these patients with congenital heart disease. Now, let's meet our last patient in the CardioNerds clinic. We have Mr. Thomas Brady here, who is a 70-year-old gentleman with a history of hypertension, diabetes, heart failure with preserved ejection fraction. He came to us after experiencing a syncopal episode. It happened randomly with no warning signs or prodrome. His family described it lasted around 10 seconds. Further workup is ordered, including an echo that's unremarkable and an event monitor that shows bradycardia to 40 beats per minute and paroxysmal episodes of atrial fibrillation with conversion pauses lasting up to 10 seconds. Dr. Knights, can you explain to our audience what is happening here and how it occurs?
You presented an older patient with paroxysmal atrial fibrillation and syncope and heart failure with preserved ejection fraction. And the monitor, fortunately, helped you with the diagnosis. So when patients have atrial fibrillation, historically, and they have syncope, it's sometimes hard to know what the syncope was from. Was it from AFib with rapid rates? Was it from heart block? Was it from sinus node dysfunction? Or was it not even arrhythmic in etiology? So you were fortunate that you were able to capture something that was very specific. We often see bradycardia when people are sleeping, slow rates in older people, especially on drugs. But if the patient had a 10-second pause, that's pretty specific as the cause of their syncope. Most useful is an implantable loop recorder in patients with infrequent episodes so that you can really correlate their symptoms with their rhythm. But you asked, what's going on here? When patients have atrial fibrillation, their atria are often abnormal, particularly in older patients with heart failure. They develop an atrial myopathy, and the sinus node is an atrial structure. And so the atrial myopathy is often associated with sinus node dysfunction. Specifically, when patients have atrial fibrillation and convert, they can have a long recovery time. They can have sinus node dysfunction. They can also just have sinus node dysfunction and chronotropic incompetence and be symptomatic from that. But a particularly common scenario is what you just described is a post-conversion pause. So a 10-second pause, especially if it's associated with symptoms, is an indication for a pacemaker. Now, it's also common that these patients are on multiple medications that may be aggravating the situation. And depending on your judgment, how high the doses of those medicines are and how long the pauses were, you might be able to just stop their beta blockers and see how the patient does clinically. But it's likely that when the patient was in AFib on the monitor, they had rapid rates, and you're going to have to continue their beta blockers or even give them more. And so this is a pretty common scenario for implantation of a permanent pacemaker.
One of the questions that comes up sometimes is regarding the fact that a lot of patients with tach-brady syndrome, essentially, their most symptomatic presentation of their sinus node dysfunction is these post-conversion pauses. And so the question is asked, if we are able to successfully treat their atrial fibrillation, specifically with an ablation, could we possibly avoid a pacemaker for some patients with tach-brady syndrome? What's your approach to that question and to that scenario?
So Kelly, that's a very good question. The earlier patient was a little bit older, had some heart failure, and had a 10-second post-conversion pause. And so I would probably recommend a pacemaker. But you raise a very important concept that should be considered, especially for young patients. So there are patients who in their 40s and 50s who have frequent paroxysmal atrial fibrillation, which probably has resulted in some remodeling of their atrium and their sinus node. It doesn't mean that they've really developed true atrial myopathy and sinus node disease. And if you can get rid of their atrial fibrillation or greatly reduce their AFib burden, their sinus node function might improve. So there are certainly patients who have post-conversion pauses, who have paroxysmal atrial fibrillation, who, if they undergo an ablation procedure that eliminates or greatly reduces their AF burden, can avoid a pacemaker. So it should be considered as a strategy in those patients. I think it's sometimes overly considered in older patients who probably are going to end up with a pacemaker anyway. But certainly in a young patient, you should do everything you can do to avoid a pacemaker.
Absolutely. That strategy makes a lot of sense.
Thank you. Those are really important to consider. So, Dr. Knight, what message do you have for our young trainees here when managing these challenging AFib cases in the clinic or on the floor?
Well, you presented several, I would say, complex cases. Some are very rare. Pregnant women with persistent atrial fibrillation, patient with tetralogy of Fallot with atrial fibrillation. But then you presented some that are a little more common, like the last patient who has atrial fibrillation and sinus node dysfunction and heart failure. What I would hope is that you're very comfortable and experienced and exposed to a lot of garden variety of atrial fibrillation. So we like to talk about atrial fibrillation and categorizing it as paroxysmal, meaning less than 7 days in duration, often just a few minutes or hours, a persistent, lasting more than 7 hours and requiring cardioversion, or long-standing persistent AFib where it's persistently present for over a year. But is it just the tip of the iceberg? So what we really want to know when you see a patient with atrial fibrillation and you're considering the three usual treatment strategies and goals, which are stroke prevention, rhythm control, and rate control, is to have a very comprehensive view of everything that's going on with that patient that will determine the therapy. So if I were presenting a patient who's come to the clinic with atrial fibrillation, I would want to present it as the following. I would want to tell my patients or the referrings or my attending if I'm a trainee that this is, for example, a 75-year-old man with recurrent paroxysmal atrial fibrillation for the past 5 years with a very low burden who presented with sustained persistent atrial fibrillation of unknown duration associated with heart failure. He also has a CHA2DS2-VASc score of X. He also has some heart failure symptoms and is very symptomatic with his atrial fibrillation, but has a normal ejection fraction. He had a normal stress test a year ago. He doesn't have coronary disease, and he has normal renal function. And I think that this patient needs X or Y, in this case, probably a cardioversion and possibly addition of other rhythm control strategies such as an ablation or antiarrhythmic drug therapy. So the more patients you see, the more complex you start to realize every patient is, and you'll get more efficient at seeing these patients. I think when you see a complicated patient with atrial fibrillation in the clinic, it can take a long time to sort things out. But if you're regularly experienced at coming up with a treatment plan on these patients, you know what the relevant issues are. I think the opposite end of the spectrum is a common problem where someone comes into the hospital with some palpitations and they're presented as, well, this is a 80-year-old man with a history of chronic atrial fibrillation. He's in atrial fibrillation. We're just going to rate control him and anticoagulate him. Well, the word chronic can mean they've had recurrent paroxysmal episodes for 30 years, or they've been in it constantly for 30 years. And the treatment for that patient is very different depending on those two possibilities. So the word chronic and, things that don't really give you a sense of what's their true pattern of AFib are not helpful. So I would encourage everybody listening to see as many patients as they can with atrial fibrillation during their training. I would encourage people to be comfortable using all of these 6 antiarrhythmic drugs that we talked about. There was a time when general cardiologists routinely would start flecainide, propafenone, amiodarone, would know how to do that, would know what to look for, what are the contraindications, indications, whether to get an EKG, whether to do it in the hospital setting with dofetilide or sotalol. At least be comfortable doing that, because not all these patients who have a new diagnosis of atrial fibrillation need to immediately see an electrophysiologist, or often can see an electrophysiologist. So get very comfortable with your favorite oral anticoagulant, whether it's Xarelto or Eliquis or Pradaxa. Get comfortable with one of those and know the nuances of dosing. Get very comfortable with beta blockers and calcium channel blockers for rate control. We rarely ever use digoxin anymore. And be comfortable with the 6 antiarrhythmic drugs, what the indications are, contraindications are, and what good doses are to start patients on.
Yeah, I think that's just absolutely phenomenal advice. And I really appreciate you going through all of that. I think this comes up, honestly, very frequently in our practice. There can be quite a long wait time between a patient who is diagnosed with atrial fibrillation and when they eventually see electrophysiology, and many steps along that way where intervention could have happened and unfortunately doesn't. So, a patient, just like what you were saying, a patient comes into the hospital, gets diagnosed with symptomatic atrial fibrillation, rate controlled and sent home like you described earlier. And they get set up with an appointment with cardiology. It takes them a few months to get in to see cardiology. Cardiology says, well, you really should have an antiarrhythmic or some form of rhythm control. And unfortunately, I feel like, at least in my much more limited experience than you, the frequency with which even general cardiologists are prescribing antiarrhythmic medications beyond amiodarone seems to be much lower now than it was historically. So that patient gets referred to EP. It's another few months before they see EP. And now by the time this person is, potentially cardioverted and started on an antiarrhythmic or talked about for an ablation for a rhythm control approach, it might be 6 months of continuous atrial fibrillation in some situations, which is just a huge disservice to the patient, both symptomatically, quality of life wise, and outcomes for, our ability to control their atrial fibrillation at that point potentially has diminished. So I think a really, really important point there to become familiar with these medications so that you can do right by your patients.
Completely agree with you. You described a common scenario. I just think that the days of a patient coming into the hospital and seeing their primary care the next day who coordinates their care with subspecialists, they're just not there anymore. It's patients get referred from specialist to specialist and there's long wait times. So if a patient develops atrial fibrillation, try to do everything you can at the beginning as possible. We have a very good outpatient cardioversion service. They don't need to see an electrophysiologist to get cardioverted. We have actually a system where we do probably 4 to 10 cardioversions a day. And we have a nurse practitioner who's credentialed to semi-autonomously perform cardioversions with an anesthesiologist providing the sedation. So at most places, you can refer a patient and get them in quickly for a cardioversion. If they're symptomatic and you started them on rate control and anticoagulation, and you think using some common sense that they're persistently in atrial fibrillation, don't order a 30-day monitor and refer them to EP. Get them cardioverted so that they can feel better and you don't result in all the remodeling that happens while they're staying in AFib.
Absolutely. And this is a question we ask all of our experts on all of our episodes, but I'm curious, Dr. Knight, what makes your heart flutter about atrial fibrillation management, challenging cases, or just electrophysiology in general?
Great question. I've been doing this since I was at University of Michigan in the early 90s with Fred Marotti when ablation was just a new thing and it was super exciting then, mostly for SVT. Started doing AF ablation in about 1999 with radiofrequency. About 15 years ago, we switched to cryoballoon. So what makes me excited now when I go to work is that we have pulse field ablation. We have PFA as a new energy source for ablation. It allows us to be more efficient, more predictable procedure times. It allows us to ablate a whole lot more territory safely. We can ablate the whole posterior left atrium and the pulmonary veins. There are now 4 commercially available PFA catheters in the United States and a lot more coming. And so the short answer is that there's never been a change of pace this fast in EP that I can think of in the last 30 years. So the rapidity of change right now in our tools that we have to do ablation with is really incredible. And for those who are training in EP right now, you're doing it in very exciting times.
Well, Dr. Knight, thank you very much for some incredible teaching and some incredible insights from your years of experience treating atrial fibrillation. Thank you all for joining us and take care.
Thank you very much for the invitation for my first CardioNerds podcast.
An official nerd now.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.